Welcome everyone. Welcome to our webinar organized for the ISUOG Congress that is in a virtual edition this year. I would like to thank you very much for joining this event. This is one of the 3 different clinical activities that we arranged for ISUOG. First, I introduce myself. My name is Luca Mastrogirolamo. I'm International Clinical Support Manager, and I will be your facilitator for today. I'm very pleased today to have here for you with us Professor Julene Carvalho. Professor Carvalho is a well-known fetal cardiologist. She's working in UK in St. George's and Royal Brompton Hospital. She's heading the Fetal Cardiac Center. And she works very close to obstetrics and fetal medicine specialists, especially to improve the scanning of the fetal heart. She is also running international courses to train and improve the recognition of congenital heart diseases, and also to show how to get better outcomes and performance for a more secure diagnosis. So I'm very pleased to have her here today, and I would like to thank her very much. Thank you very much, Julene. Today she will present us a lecture with the title, How to Improve a Sequential Analysis on Fetal Heart. After the lecture, there will be a Q&A session. So if you want to place a question to Professor Carvalho, just go to our booth. You will find a moderated chat where you can place all your questions. So thank you very much, Julene. So I leave the stage to you.
Well, thank you very much, Luca, for the introduction, and good morning for those in the UK, good afternoon or good evening to the delegates who are in many parts of the world. It is a pleasure to participate in this webinar, which is part of the ISUOG World Congress. And I was asked to talk about how to improve sequential segmental analysis. I'm a very fan of doing a sequential analysis of the fetal heart. So briefly, when we try to analyze particularly complex abnormalities, it is important that we think about the heart as 3 cardiac segments: the atria, the ventricles, and the arterial trunks. And these are connected by 2 ventricular junctions: atrioventricular junction between the atria and the ventricles, and the ventricular arterial junction. And if we can put those pieces of the puzzle together, we are a long way towards making correct diagnosis. So these 3 segments are also part and very similar to what is described in the ISUOG guidelines for cardiac screening. So if we think about the situs, 4-chamber, outflow tracts, and 3-vessel trachea view, we are actually looking at the sequential analysis of the heart from the situs or the atrial position, the ventricles, and the arterial trunks. So everyone here who is used to doing obstetric screening should be very familiar with the putting together the 3 segments of the heart. So very briefly here, because this is quite basic for the high level of attendees in this Congress, but it's still worth going through our view for the abdominal situs. Obviously, beforehand, we need to check fetal laterality, identify the left side of the baby, and then we see the aorta to the left, the IVC to the right, and the stomach. We then move on to the 4-chamber view, and having established atrial situs, we look at the morphology of the ventricles, and then we put the 2 pieces together of atrium and ventricles through the atrioventricular connection. And then further up, moving towards the outflow tracts, we have the left and the right ventricular outflow tract, the 3-vessel and 3-vessel trachea view. So this is part of the screening, and the images are in black and white. So today we're going to concentrate a bit more on what comes before the atria, the venous connections, and the arterial branch, the smaller vessels, and very briefly touch on some abnormalities just to show examples of how we can improve some of the details. Now, first of all, it's very important that the image quality is good. 2D or cross-sectional image forms the basis of looking at the anatomy, and we can improve by changing contrast and by using a lot of post-processing that modern equipment have got to offer. So with the system Arieta 850, the post-processing carving the image, which is to accentuate differences and emphasize the boundaries. So this clip here has been prepared to show a change in the quality of cleaning or carving the image. This next slide shows that process to a large extent, and you can see that there is still some spontaneous contrast. It's quite nice to see the ventricular septal wall, but we start losing some definition of the subvalvar apparatus of the mitral valve. So it's always a balance as to how much we clean the image and how much we leave so as not to lose the details. So it's better to clean but yet maintain a detailed anatomy. So this is the original image, and this is with some carving of the image where you can see there is a cleaner image, but we still see details of the subvalvar apparatus of the mitral valve. So it's always a balance as to how much we do that. So one of the things I'm going to concentrate more today is adding color, because you can see here how many more details we can see when we get the color just right. It's not part of the cardiac screening protocol, but I'm sure lots of people around the world use color. So I'd like to highlight how important it is and how we can improve the details of the sequential analysis of the heart. So this is an usual cross-sectional image in 2D, black and white. This conventional color flow, which now has this glossy appearance, it gives a three-dimensional aspect to the blood flow. It's quite a new technique, and I think it's catching people's eye very quickly. So here you can see that we start to see more details once we put color. We see more of the aortic arch, the transverse aortic arch, than we see on cross-sectional image alone. And I chose here a bidirectional power Doppler. So we have the conventional color, the power, which is much less dependent on velocity and the angle, because it picks up lower velocities. And it gives a lot of definition. So if I stop here for a second, we can see the details of the branch pulmonary arteries much more clearly than if we use conventional color. You can also use another color modality, which is E-flow, but I'll show that as I go along in the other slides. Now, one of the uses of the color might be to fill up the space within the cavity. This is an example of a fetus that had a right ventricular cavity, as you can see here, smaller than the left ventricular cavity. And how much smaller is this? Is this a ventricle that will be suitable for the normal biventricular circulation? So when we add color, and this is power Doppler with unidirection, so there's no up and down in the screen, it's just one color, and you can change the color as you like. So you can see that that cavity is much more significant than it appears initially on the 2D image. And this is the glossy appearance on the same image. Now, another aspect that you might have seen before, because I've been using it for a long time, and is something I call just flow technique. And I prepared this clip to show how easy it is to do that. You can see here a nice E-flow image of the aortic arch, but the boundaries of the vessels could still be better. So one way of improving that is to reduce slowly, progressively, the gain through the cross-sectional image. And you can see at the end how many more details we have of this aortic arch. And it's a very simple, you don't need any fancy equipment, just by reducing the color, the gain on the cross-sectional image, and if necessary, the TGC as well. So very useful, very beautiful, very pleasing to the eye. It gives more details, as we'll see in subsequent images. So this is what I'm going to try and accentuate today, how important it is to look at the details and how useful the color, in particular power and E-flow, can be for seeing those smaller details of the smaller vessels. So if we go back to our sequential analysis starting from the situs, we have here the transverse view through the abdomen with the aorta to the left and the IVC to the right with the stomach to the left. And as soon as we put color, we can see already that we see details that we can't see without the color. We can just about see the umbilical vein coming here, and it accentuates the ductus venosus. A lot of people see the ductus venosus, particularly on a sagittal view, but it is very useful to do it on a transverse view where you can do also your pulsatility index. So from here, we can follow the umbilical venous return, plus some of the hepatic veins coming from the liver, joining here and eventually joining the inferior vena cava, and that coming into the right atrium as indicated here. So we start to follow the vessels that are coming into the heart before we come into the atrial chambers. And as I said, we can do the pulsatility index through a transverse view. And sometimes I have visitors to our unit and they are, oh, do you do the pulsatility index here? Why not do it on the sagittal view? I think you can do on both. I personally prefer to do it on a transverse view. It's very easy to demonstrate. So all of this can be incorporated into the routine looking at the fetal heart. Now I highlighted here, maybe you haven't noticed before, that to look at these smaller vessels coming into the atrial chambers, we really need to reduce the velocity, more like an obstetric velocity rather than a cardiac velocity, so that we can see the details and moving from the abdomen into the fetal chest. We can see that the velocities across the pulmonary veins just appearing here are also low, but if we look at the intracardiac velocities and the arterial velocities, it's all a bit of a blur because this is a too low setting for looking at the aorta and the pulmonary outflow tract, but very nice for the pulmonary veins and the umbilical venous return as we've just seen. So coming back to just moving from the abdomen into the chest, the first chambers we're going to see here are going to be the atrial chambers, and we can see here pulmonary venous return from the right lung and from the left lung into the left atrium. So very clearly, again, velocity is very low, kind of rich color, which helps you see the veins entering the left atrium. I would suggest that when looking at pulmonary veins, that you use a geodisplay where you can see a cross-sectional image as well as the color flow for two reasons. If we have abnormalities of the pulmonary venous return, the veins actually come very close to the atrial chamber. So if you don't have this image on one side of the screen, and if the underlying image here is not very clear, you may think that the veins are coming into the atrial chambers, but they could be coming to a confluence on the back of the atrium. The other point is that it's important to see where the atrial septum is, and here it's very clear, but it's not always the case. So you want to make sure that those veins are coming and actually entering the left atrial cavity. Now, if you've seen me talking about arrhythmia, you would know that this is my preferred method of looking at the cardiac rhythm. And it's very easy to do by putting your sample volume of the Doppler within the lung parenchyma. And you can see here simultaneous recording of the pulmonary vein coming towards the left atrium and a pulmonary artery going away from the heart towards the lung. And that's a very typical signal which represents the atrial systole, then ventricular systole and beginning of diastole. And on this side, you see ventricular contraction. So it's a very easy way, even if the image quality is suboptimal, you can still get good Doppler signal to assess the one-to-one relationship of the rhythm. And you can also measure the AV interval if you need to monitor for heart block, for example. So very useful. And this is something that I use routinely in every single patient I do, so that when you have an arrhythmia, you're already used to doing that. But also, if the signal in the pulmonary veins may be abnormal if you have an abnormality of pulmonary venous return, particularly if it goes below the diaphragm. Now, coming back again to the cavity and the use of power, we can see, is a clip that I've shown before. the richness of the color coming up to the 3-vessel trachea view, which is the higher level that goes through the 5 screening planes on the cardiac screening during normal pregnancies. We can see here the color highlights structures that are not necessarily well seen during the 2D image because it has a higher sample volume area. But can we go higher than that? So we've gone from the situs, 4 chambers, and the vessels. Can we go higher? And the answer is definitely yes. So there are further levels up into the mediastinum, and if we want, we can go into the neck as well to look at the arteries. So in here, just above the level of the 3-vessel trachea view, I have reduced the scale, increased the gain a little bit to try and pick up these little vessels here, which are coming from the subclavian arteries, which are the internal memories. And this has been described that they are around or surround the thymus, which we may see on cross-sectional image, but this facilitates and it shows you where the thymus is. So in this image as well, I would like to point out that just above the aortic arch, we have a vein coming here, usually from left to right, because it will join the right superior vena cava, which is the innominate vein, also called the left brachiocephalic vein. So these are details that sometimes are very important. But for example, if you have a baby who's suspected 22q level, you'd like to see if you can see the thymus or image the thymus. So we're going through the normal structures that are there, that we're just elevating and going beyond that 5 plane of the cardiac screening. So very nicely shown here. And if we go a bit higher up, we can see the 3-vessel trachea view. I've highlighted the trachea here. The innominate vein is coming. We see a little bit of this, the internal memories, but we also see here the first branch of the aortic arch going towards the baby's right arm. And you notice that the internal memory is a branch of the subclavian artery, and that's the left subclavian. And you just see here the beginning of the left internal memory. So this is obviously important, particularly since nowadays there's a lot of detection of an aberrant subclavian artery. So this is the normal position, and that's the way to image the normal subclavian artery. It'd be also important to learn how to use this because of the higher detection rate now of vascular rings, and seeing the position of the subclavian arteries is very important for complete diagnosis. So these are the subclavian arteries, right and left. And you can see that the right subclavian artery courses in front of the trachea. Now, from a different angle, it is a different fetus. I'm just going to do a brief sweep between the pulmonary outflow tract, and you can see here, highlighting by the color, the branch pulmonary arteries, and sweeping above that, we come to the 3-vessel trachea view very quickly, and that's the transverse aortic arch. And because the arch is to the left of the trachea, the first branch of the aorta goes to the right, and it will divide into the subclavian artery, which you can see here, and the carotid, which will go up vertically into the fetal neck. So very nice, very easy to show the subclavian artery. Now, moving away from the transverse views, looking at the venous return, the systemic venous return from a different angle, you can see here this is a sagittal image of the fetus with the head on this side, and we see the superior vena cava entering the right atrium, which is more anterior than the left atrium, and we see here the inferior vena cava also entering the right atrium. Now, if you remember from your 3-vessel view, the aorta, of course, is very close to the superior vena cava. So sometimes the two of them are almost merging in this view. And as you see, as soon as we put the color, we see a little bit of the SVC, but then we see the aortic arch. And I just applied here that trick to reduce the gain and to see that we can do that with conventional color as well. But I think to get more details, I prefer to do that with power Doppler or E-flow. And that's the view here, which you see enormous details of structures that perhaps you never thought you could image. So I'm going to take you a bit slowly on this one. So this is the inferior vena cava coming into the right atrium. We see here a little bit of the left atrial appendage. Over here, right atrium, the aortic arch with the head and neck vessels, and just sometimes we see a little bit of the SVC coming here into the right atrium. So there's so many details in some of these images that really, to understand the normal anatomy, we do need to slow down and try to identify all the structures. And it's just very pleasing to the eye to see this, the heart kind of jumping around. So here, the aorta will come from the middle, but this is the SVC, the end bit of the SVC coming into the right atrium. Just let it play again, because the moving image is quite nice. So the left atrial appendage here, very clearly. Now, this is also a beautiful image that I think teaches us a lot about the fetal circulation. And I chose to start on this frame for the clip, where you can see that from here is the umbilical venous return going through the left atrium, that preferential flow that will bring oxygenated blood to the left atrium. We see a little bit of the superior vena cava coming to the right atrium, and just the end bit of the inferior vena cava, and obviously a very beautiful aortic arch. So if I play that, we see there are many more details, such as the azygos vein coming here into the SVC. And if you're not used to looking at this very fast moving image, we can just slow it down. So this is the right atrium here, the inferior vena cava coming, the azygos vein joining the superior vena cava. Right at the beginning, we have a beautiful flow coming from the umbilical vein, turning into the left atrium, and the SVC coming here a little bit to the right atrium, very close to the aorta. So I just let it play again, because it's so much information, such rich information about the details, which of course, if we know that, it will facilitate when we have abnormalities of the heart to try and understand all the venous returns. So beautiful here, the azygos joining the superior vena cava. Now, we talked about venous connections, talk a little bit about the arterial branches. I'm just going to illustrate a little bit on associated abnormalities, very briefly, because there are so many of them that we would be much beyond the time of the webinar. So we start with a 4-chamber view. And if we look at this on a cross-sectional image, we say it's a normal 4-chamber with all the structures, symmetry, offsetting, flap valve of the foramen, apex of the right ventricle a bit more trabeculated, left ventricle more smooth. So a normal 4-chamber view. If we add color, there we have very clearly an apical muscular ventricular septal defect. You see that the velocities are low here because we are away from the atrioventricular valves and the blood is slowing down. They will accelerate again as it goes up the outflow tract. Now, is it important to find these small ventricular septal defects? Well, the small ventricular septal defects, as you can see here in this just flow image, you can see the integrity of the rest of the septum. It is important to see them, and not that we are actively looking for them, but if we do see a small ventricular septal defect, we need to have a very close look at the other structures, because sometimes there are associated problems, in particular coarctation of the aorta. So this technique here, if you use it in patients who have a higher BMI, if you can feel the cavity, not necessarily because of VST, but it helps highlighting the cavity separate from the ventricular septum, which is mostly intact with that apical VST. So I would encourage you to start doing this just by reducing the gain. And of course, if we look at the ventricular septum, we are not interested just in the apical portion. And it's very useful to use color, particularly in a baby that's not necessarily in the best position, with the spine on the top and looking through the ribs here. And actually this angulation coming here is perfect for looking at the septum and giving the septo-aortic continuity. So as you can see here, left atrium, left ventricle, ventricular septum. It is very important to determine that there is continuity between the interventricular septum and the anterior wall of the aorta. We can see the aortic valve clicking here. So it's very important to see that in great detail, even if the baby is in an unfavorable position or perceived unfavorable position, but actually quite a good angulation to look at this portion of the septum, which of course contrasts with a baby that has the tetralogy of Fallot, and sometimes that overriding of the aorta, as we can see here, with some anterior deviation of what we call the outlet septum, because this is malaligned from the rest of the septum, may not be so easy to see in some patients, depending on fetal position, maternal BMI. So very careful look at this area, because quite often VSTs in this area can be overlooked. If it is part of a tetralogy of Fallot, many times this is picked up on the three-vessel trachea view, but sometimes you can have this large ventricular septal defect without having tetralogy, just a VST. So, and of course, if we apply color to that, it confirms you see flow coming from the right ventricle and the left ventricle joining the ascending aorta. So again, this is all color information about velocity, about the anatomy. It complements the image we can get on cross-sectional echocardiography. And this example I put here, although we may see that this is a right aortic arch, patient had a high BMI, 44, we still get good image, perhaps not as perfect as we'd like, but those are the limitations of day-to-day practice. But if we add the color, you can see that it facilitates very much the confirmation that this aortic arch is to the right, that's the superior vena cava. We can still see the trachea very clearly, and even on this image here, we see the pulmonary valve very clearly as well. So color is very useful, and I'm hoping that at some point, color is going to be introduced onto the normal ISUOG cardiac screening views. Let's wait for the next version. Another example of a right aortic arch and the utility of using the subclavian arteries and the internal mammaries to delineate the thymus. You know that patients that have a right aortic arch are at increased risk of chromosome abnormalities, including 22q11 microdeletion. And although in this case the image quality is quite good, we can see here the demarcation of the thymus without putting the color. That's not the case for all patients. So I would use it on a regular basis so that when we have a more difficult patient, we can see on E-flow in this case, that's the innominate vein, that's your aortic arch on the right side, that's the trachea, and this is the left subclavian artery arising behind the trachea and causing anomaly to the left arm. And in this case, as I said, the thymus was clearly visible, but is highlighted here by the right and the left internal mammaries. As I said, the internal mammaries are branches of the subclavian arteries. Another example, case of pulmonary atresia, ventricular septal defect. We can see here aortic overriding, and on a sagittal view, see a nice large aorta and very clearly flow reversal through the arterial duct. So there are different types of pulmonary atresia VSD, so it's important to determine, is this the duct dependent? Are there collateral vessels? So the color is essential to make that complete diagnosis. Now on the same patient, same fetus, we see here a transverse view through the mediastinum, and on this still image we can see the aorta, which is bigger, and we'll see when I play the clip that the transverse arch will come here. Underneath the arch, you have the arterial duct, which then hit the pulmonary, which is atretic, and then it goes into the lungs, one lung and the other lung. So aorta. So although there is pulmonary atresia, the branch pulmonary arteries are visible. There is no main pulmonary artery. The branch pulmonary arteries are here. They are confluent. It's a large aortic arch. And that helps counseling the patient and know what to do with the baby. For example, in this case, you would do either a stent of the arterial duct or a shunt operation in the first few days of life. So some of these details are very clear, very important. We also see a little bit of the azygos vein coming here, just as a flash, that pink shear coming to the SVC. So some of these details are very important. If you are a cardiologist, they are essential. You cannot do fetal cardiology without getting these details for appropriate counseling of the families. If you are an obstetrician, I think we should always aim to learn more and to do more. So hopefully this will be stimulating you to use color on your daily practice. So another example of help from color, you can see here, not usually diagnosed antenatally partial normal pulmonary venous drainage. You can see that on the cross-sectional image, even if the image is very clean, it would be very difficult to say that we have a vein here from the right lung coming into the right atrium. See, that's the top end of the atrial septum, which you can compare, and that's the importance of doing this dual image display, because we can see a normal pulmonary vein coming to the left atrium from the right lung, a normal vein from the left lung, but that anomalous one coming into the right atrium. This baby also had a small ventricular septal defect. Now, how far can we go using these? So I just chose one example of a fetus at 15 weeks with a previous history of congenital heart disease on the previous child. And this here we can see an overriding aorta. You can see how the color helps the flow coming from both ventricles into that vessel, I should say, rather than the aorta. There's an overriding vessel. That's the semilunar valve, potentially the aorta, but it could be a pulmonary, it could be a trunk. So the color showing here flow from the right and from the left ventricle. This is a bidirectional E-flow into a vessel that we still need to determine. We can only say it's an overriding vessel, but what is the diagnosis? So we need more details to be able to counsel the family, even at this early stage of pregnancy. And this here is the big vessel, which starts off actually as a trunk. We can see here on the still image, this is the big vessel overriding, which then gives rise to a smallish pulmonary artery, which bifurcates. So this is an arterial trunk. And obviously after giving rise to the pulmonary arch, which we can see here as well, it follows through as an aorta. It also was a right aortic arch. And here in this clip, you can see the detail, the fine detail. These vessels are extremely small at 15 weeks. So obviously for getting these details at 15 weeks, we need a combination of what you're looking for. So you need to know the anatomy, the possibilities, not just assume that an overriding aorta is tetralogy of Fallot, like in this case it was not, it's a truncus arteriosus. And you need to know what you're looking for. You need a bit of cooperation. It helps if the baby's in a good position, and obviously maternal BMI and the maternal condition helps as well. So combination, but it's essential that we learn how to use these techniques in the normal heart, so that when we have an abnormality, we are used. Most of the time, we control the frequency for the color, the gain, and the velocity, the PRF. So this is the truncus arteriosus, as the image is indicating. So I quite like this picture because it's kind of very pensive with the fetus. You know, what else can we do? And I think there will always be something else. One, because we are interested. If you're participating in this webinar, you're interested, and you're interested in the fetal heart, and I'm very glad for that. The companies are having wonderful equipment these days with lots of possibilities, digital imaging. So we do need to make use of everything that's there and make the most of it for completing the sequential segmental analysis of the fetal heart. I hope you enjoyed the session, and I thank you again for taking part and coming here. And hopefully on the day, there will be some questions that we'll try and answer for you. Thank you very much for your attention.
Dear Professor Carvalho, thank you very much for the lecture. It was really interesting. You give a very nice extent of the possibility how to improve the sequential segmental analysis. So we saw a lot of nice cases and tips and tricks how to improve this fetal scanning. So I would like to thank you very much for joining, all of you, and would like to thank Professor Carvalho as well. And for all the audience, if you want to place question, there will be the Q&A session in our booth. Just enter on the exhibition area, go in our booth, and you will find a moderator chat where you can place all your question to Professor Carvalho. So I would like to thank you very much, and I hope to see you also in the next webinars that we will have on the following days for ISUOG. So thank you very much.